Now we can discuss about the pathology of CDH. Present evidence suggests that there are two distinct types of dysplastic hips. First is those dislocated at birth, classic CDH, and the second one is those dislocatable after birth. The first are primarily due to a hereditary faulty development of the acetabulum and are difficult to treat. The second are due to underlying joint laxity, with a precipitating factor causing the dislocation. Following changes are seen in dislocated joint. Now, this is the diagram pathology of CDH. We can see in which elongated capsule, inverted limbus, and fibrofatty tissue. Femoral head is dislocated upwards and laterally. Its epiphysis is small and ossifies late. Femoral neck is excessively anteverted. Acetabulum is shallow with a steep sloping roof. Ligamentum teres is hypertrophied fibrocartilaginous labrum of the acetabulum may be folded into the cavity of the acetabulum. Capsule of the hip joint is stretched. Muscles around the hip, especially the adductors, undergo adaptive shortening. Now, diagnosis. Diagnosis is easy in an older child but may be very difficult in younger children, especially during infancy. This is because of subtle clinical findings and difficulties in interpreting X-rays of these children. Now, clinical features. Clinical features is based on the at different ages. First is at birth, the next one is early childhood, the last one is older child. First of all, explain at birth. Routine screening of all newborns is necessary. The examined pediatricians may notice signs suggestive of a dislocated or dislocatable hip, as discussed subsequently. Early childhood. Sometimes the child is brought because the parents have noticed as asymmetry of creases of the groin and limitations of movements of the affected hip or a click every time the hip is moved. Older child. CDH may become apparent once the child starts walking. Parents notice that the child walks with a peculiar gait. Though there is no pain, on examination a CDH may be found to be the underlying cause.